Session is being recorded. Awesome. So this is the peer teaching session about OSCE teaching, examination teaching, on the hand examination, and on the GALS examination. So we're recording this for anyone that wants to watch this later. Any of you keen medic boys and girls? Hopefully you learn something from this. This will be useful for you guys to use other than the geeky medic videos, because it's going to be specific to the Sheffield examination handbook, and that's the mark scheme essentially. That's what they're going to be marking you on. So yeah, I'll start with my presentation on the hand exam. Yeah, my name is Prakhar Gupta. I'm one of the 3A students, but I'm going to be intercalating next year.
And I'm Ravi Patel.
Yeah, he's Ravi Patel.
I'll be doing the GALS exam.
Mm-hmm. So what we're going to go through in the hand examination is just going to talk to you a little bit about what the OSCE is about and what you're going to be going through. I'm going to talk you through the examination and then some general tips and advice at the end. Right, I don't know what that's for actually. Oh no, I don't think the things that I've highlighted have come through. Oh well. So what will come up on the OSCE? The 3 main system exams will always come up. That's a definite. I can bet you a 5 on that. And then you'll have possibly 1 more neuro. That's very likely, and then 1 anything else. That can be a thyroid exam, a diabetic foot exam, or any MSK exam. Okay, so there's 5 exams. And the patients that will have any signs or abnormalities, they are most likely going to be common ones, as they have to have lots of patients with the same signs to keep it standardized, right? There's going to be about 12 groups of people doing it at the same time. Therefore, they need about 12 patients with the same exact signs. And to get, these patients need to be stable as well. And they need to be they need to have signs and symptoms so that when you're testing for them, you don't make it worse for them, if that makes sense. So, for example, in the knee exam, you're not going to get patients with, acute or, ACL injuries or, things like that. When you're doing the posterior draw test, you might hurt them if you don't do it properly. So these are your resources. The clinical examination handbook, you can find in Minerva. Geeky Medics, big one, because you're actually seeing UK OSCE-based videos for 3rd year medicine OSCEs. Great stuff to see how to do it, but just keep referring back to the examination handbook to see what you need to do and what you don't, because there's some things that Geeky Medics add that you don't, and they miss out some stuff as well. Funnily, the examination of the hand is on page 69. I'd put that on. Great stuff. Okay, so it hasn't highlighted again, but I'm going to go through the examination. So MSK examinations in general, you introduce yourself. So there's an acronym that I'll show you later. You explain what the examination is about, etc., etc. Then you inspect, so you're just looking, right? And then you palpate, so you're feeling. Then you're moving the joint, the movement, the parts of the body. You want to do that passively and actively. So passively is making them do it themselves without any input from yourself. Actively is where you make them go floppy and you do it yourself for them. And then you have special tests, testing for special things. And then you conclude and summarize your examination to the examiner. So there's your acronym. Wipe, wash your hands, introduce yourself, get your patient details right, ask them for permission, informed permission, so informed consent, so you need to explain to them what's going on, and then expose them adequately. So for the hand examination, this isn't quite as important, but for example, for a knee examination, you want to expose them adequately, which means exposing them enough so that you can examine them properly, but not exposing them too much. So you don't want them, for example's sake, their trousers off fully If they're just wearing their shorts, it's fine. You don't need to ask them to take their shorts off.
And
Or-
usually in the OSCE they will be wearing shorts, but it's always important to remember to expose them adequately in real life.
Exactly. Yeah. The OSCE, they'll try and make it normally as easy as possible.
Usually.
Yeah. Always offer a chaperone. Doesn't matter what examination you're doing, just to be on the safe side. The chaperone is the examiner, so be like, would you like a chaperone? If they say yes, it's the examiner. And ask for any pain or discomfort anywhere else before you start. So, when you're looking at your hands, before you look at the hands, do a general inspection. Have a look at them sitting on the bed or lying wherever they are standing. Look at their surroundings. Sometimes they give you clues, and you should pick up on those clues. Some medication, some walking aids. It can be anything, and it will normally be something that you can talk about to the examiner at the end. Say that you've noticed. You look at your nails for the hands. You look at the dorsal surface. That's that surface. Palmar surface, this surface. And you look at your elbow. That's for the looking part. Let's go through that. So when you're looking at nails, you're looking for any abnormalities. You got to make it obvious. Have a look at. Ask them, hey, can I have a look at your nails? Can I have a look at your hands? These are the two pathologies that you can find: clubbing, splinter hemorrhages. I put the common ones on this presentation, the ones that you're most likely to see. So when you're looking at the dorsal aspect, ask them, can I have your palms facing down, please? Look for skin color, pallor, scars, any deformities. Common ones would be rheumatoid and osteoarthritis signs, so these nodes that you find, deformities, certain ones that are very typical for arthritis. Then ask them to turn their hands over, look at their pallor again, look at some scars again, looking for deformities. So that's a Dupuytren's something. I forgot how to say that. Dupuytren's. Thank you, Ravi. And some other pathological signs. I think those are for infective endocarditis. But yeah, it's all in the handbook. So moving on from looking and inspecting, you're going on to feeling. Okay, this is the palpation part of your examination. So when you're doing hands, there's 4 categories that you're looking for when you're palpating. First, it's a very simple one, the temperature. You use the dorsal part of your hand to check for temperature, and you do it at the same time for both hands, if that makes sense, checking for any unevenness between the two. For the actual palpation, main tool will be the MCP squeeze test. These are the MCPs here. Bimanual joint test. So bimanually meaning you're using both of your hands to manually test for the joints. And then there's some others that I'll talk about. Third one, you want to look for any problems with their neurological status in their hands, mainly looking for sensation and motor aspects, and then vascular, your pulses, and then an Allen's test. Make sure you're looking at the patients whilst you're feeling and palpating for any discomfort. That is a mark. They do definitely look for that. It's important. So I've divided it again, like how we inspected, into palms up and palms down. It just makes it easier. So when you've got your palms up, you're testing for temperature first. Then you can test the vascularization. You look for the ulnar and the radial pulse. And then do the Allen's test. That will take quite a long time, so they might ask you to miss that out. Then you're looking at the thickening in the eminences of your palm. So as the photo shows there, the thenar eminence and the hypothenar eminence, those are basically parts of your palm that are protruding upwards and form a bulk of tissue. You can feel them for any muscle wasting or anything that you don't feel that is right. And then sensation. This photo is brilliant. Ask them to close their eyes and say if you can feel me touching. They might give you a bit of cotton wool, or you can just use your finger. And when they've got their palms up, it'd be best to test the median and their ulnar nerves. The radial one's going to be a bit hard on the palmar surface, so we're going to do that on the dorsal surface. So palms down, test for temperature again. This is where you do the MCP squeeze, so squeezing all the MCP joints together like this. And if they do hurt for the patient, then you want to go individually, okay, for each MCP. Then you're going to do a bimanual joint palpation. That would be best if you watch the geeky videos or watch any YouTube videos. Though it would be much better than me explaining or writing anything down. And then for sensation, feel the this part of the hand. I've forgotten what that's called. I think I've written it down later on in the PowerPoint. Now we're on to our movement part. So you ask the patient, can I have you doing some movements for me? And always ask for pain before you do the movement. So we're looking to test the fingers, the thumb, the wrist, and any function that involves your fingers or your hand. Okay, so first we'll have a look at the fingers. So you want to test flexion extension, and then you want to test abduction and adduction. So for flexion and extension, flexion, extension. Oh, it's just straight. It's just straight because this is going to be your abduction, adduction. Yeah, and for abduction and adduction, you ask them to spread their fingers out and back to normal. A good way of remembering the difference between adduction and abduction for me was to abduct someone is taking them away from the place. So this is abducting. Yeah, you take a kid away, you abduct them. Okay. Now, so we're finished with the fingers, we go on to our thumb. You're looking for flexion and extension. These are a bit hard to explain. I've got the YouTube video link in the description of this PowerPoint. But your flexion and extension is going to be like this, in the same plane as your hand, if that makes sense. Let me show you, like that. But abduction and adduction will be towards the ceiling, if that makes sense. And then opposition is where you're pressing the fingers with your thumb. Brilliant. Now onto our wrist. It's a very simple one. Go into the prayer position. Try and fully flex your wrists to basically 90 degrees or as much as the patient can. And then the opposite version of that, which is put the back of your hands together. So we've done fingers, we've done your thumb, we've done your wrist. Now we're looking at functional movements. So you'll try and have them grip onto your finger. Ravi, can I have your fingers? Sure. So just making them grip onto their finger like that, and then don't let them pull out. Ask them to hold a pen or key. A coin would also work. And then undoing and doing up your buttons. Now, for the hand examination, the special tests are testing for your peripheral nerves, the ones that we looked at earlier. But not just sensation, they want to test all aspects of it. Okay, so we'll go to one that you probably do a few times in GP, if you get the chance, in 3A. So you're testing the median nerve. First test for sensation, as shown in the diagram, top of your index finger. For motor, testing the thumb for abduction against resistance. So remember the thumb going to the ceiling and then pushing down on it and seeing if they can keep their thumb up. And then there's a few different tests on the handbook, but I thought this one was the easiest. Tap on the carpal tunnel, as shown on the diagram. If they get any weird sensation, any tingling, any pain, any discomfort, you can go on to a further test that's written in the handbook. But yeah, to confirm your diagnosis, but that should take the marks. Your ulnar nerves, again, testing for sensation. For ulnar, you can just use your pinky. For motor, abducting fingers against resistance. I thought I had a diagram here. And the provocation would be ask them to grip a paper, and as shown in the diagram, a positive test for that, showing they have a problem with their ulnar nerve, will be when their thumb is flexed. They can't seem to be able to grip the piece of paper without flexing their thumb for assistance. Okay, and then the radial nerve, you're testing their sensation around the anatomical snuff box. That's around there, or the web spacing here. Both do the same thing. And then that's how you test their motor. Ask them to hold their arms out in front of you with their palms facing the ground. Extend their fingers out in front of you. Cock their wrist back, and don't let me push them downwards. And to summarize, there's lots of Geeky Medics summarize it quite complicated, in a complicated way. If you have access to the drive, there's lots of people that have written simpler forms of summarizing things. Basically, just going through the test that you've gone through. General inspection, they seem fine. You didn't find any abnormalities. Palpation was fine, there was no tenderness. Full ROM in all the modalities tested. Sensation was okay, special tests were negative, and in summary, this was a normal hand examination. And then to complete your examination, as all examinations do, you need to, for MSK, all MSK ones, you want to go for the joint that's above and below, proximal and distal to the joint that you're testing. But for the hand, it's the most distal, so you're going for the next one up, which is your elbow. So if I found any problems with their hands, I'd examine the ipsilateral elbow of the patient. Okay, brilliant. I think that's it. Oh, I've got some tips, I think. So yeah, referring to the examination handbook as your Bible, your mark scheme, keep practicing. It is just a dance at the end of the day. Most of the marks you will pass if you know the dance, even if you don't know any clinical knowledge. As long as you do the moves, you will pass. And if you have no friends like me, you can record yourself and watch it over. But best is to practice with friends, and then they can critique you whilst you do it. Geeky Medics videos are fantastic, as I said. They're UK based, therefore are OSCEs. And a lot of the time what happens in 2A, you're on your placements and you're practicing your examinations, and the consultant or the surgeon's like, no, you should do it like this way. And that goes against the handbook or goes against Geeky Medics. And if you're familiar with that, you can keep using that method and just explain to the examiner that I'm going to use this method, as it will show the same, it will show up with the same, sign. It will find the same problem. Time yourself, make sure you do that. You only have limited time. It's easy to overrun these. Just keep practicing whilst time yourself. Don't forget to revise the pathologies. And yeah, off to Ravi for his GALS presentation.
Sweet. So hi, my name is Ravi. I'm going to be doing the GALS section of the presentation. So in comparison to the GALS examination, in comparison to the hand examination, GALS is very short. And essentially, the GALS examination is a screening exam of the MSK system as a whole. It's very short. So let's get started. So basically, this is kind of briefly. Oh, we have a person that's joined. Hello, S. So essentially, the GALS exam is so it's a mnemonic. So it's gait, arms, legs, and spine. But unfortunately, this isn't actually the order that you carry out the exam in. So the GALS exam starts off with 3 questions in which you need to ask the patient. Then you assess the gait. Then you do the general inspection. Then you want to look at their spine, their arms, and their legs. So it's more GSAL rather than GALS, in fact. So yeah, you start with 3 questions. I believe it's one of the only examinations that you actually ask kind of a set number of questions, other than are you in pain? And of course, the questions that you ask everyone about patient identifiers and would you like a chaperone? I haven't included that in here, but of course you'd need to say that before doing the GALS exam. So if I can, so the 3 questions are related to function, and after you've done your after you've done washing your hands, introducing yourself, all that jazz, I'm sure you already know. You want to ask, do you have any pain or stiffness in your muscles, joints, or back? Okay, that's question number 1. Then 2, are you able to completely dress and undress yourself without difficulty? And the last question is, can you climb up and down the stairs without difficulty? Okay, so those are the 3 questions that you need to ask as the very first thing that you do in the GALS examination. So GALS is a bit different. You don't inspect the patient like you would for most exams. You in fact ask these 3 questions before you do anything. Okay, so those are the 3 questions. You just have to learn them, to be honest. There's not really any special tips or tricks I can give you. So on to the next one. We have gait. So you look at the gait before you do the general inspection in GALS. It's a bit odd. I'm not really sure why that's the case, but that's the done thing, and that's what's in the handbook. So the first thing you look at is the gait. So you'd ask the patient to walk a few steps, stop, turn, and then walk back. And you want to ask if walking is painful. And there's a couple of things that you can comment on in your presentation. So you can talk about the arm swing, the pelvic tilt, the stride length, and the ability to turn, and if there are any pain. So if, as you can see in the diagram, what's being shown is an antalgic gait. So it's kind of, essentially it's a limp, and an antalgic gait is pain on weight bearing. And there's some other types of gaits that I would recommend you familiarize yourself with. So the Trendelenburg gait, which I'm sure you will have heard of, is where you have like a gluteal nerve palsy, and a Parkinsonian shuffling gait. That's another important one that you should probably be familiar with. But the main one is an antalgic gait, and I suspect if there's any gait they would show to you, it would be that one. So be familiar with that. So that's gait. Ask them to walk, stop, turn around, and then walk back. Next up, we have the general inspection. So you're just looking at them from the front, and then from the side, and then from the back. On the front, you're looking at any asymmetry, a kind of muscle bulk, any scars that could potentially be surgical or injuries, any obvious joint swellings or erythema, or any deformities of the knee. So as you can see, and then after you do the anterior inspection, you go on to lateral inspection. So you're moving around the patient. So you're going from the front, then you're moving to look at the patient from the side. And you want to see if they have the normal spine curvature. So kind of a lumbar lordosis, normal lumbar lordosis, thoracic kyphosis, and then again the cervical lordosis. Cervical lordosis as is normal. And then you go on to posterior inspection. So looking at the patient's butt, you're going to be looking at muscle bulk, the kind of alignment of the spine. Is there kind of a bit of kyphosis, and any popliteal swellings? So potentially a common exam question is, what would you call a cyst in the popliteal region? That's called a Baker's cyst. So that's something you might want to remember. You also want to be checking for any valgus or varus deformities. So as you can see, there's normal someone standing up normally, and then varus knees, which is kind of the knees are kind of pointing outwards, and knock knees or valgus knees. And you can remember knock knees as valgus knees because the knees click together and go g for valgus. At least that's how I remember it. So moving on, we have spine. So we've just done the 3 questions, gait, and then the kind of general inspection. So now we go on to spine. So this is kind of almost a abbreviation of the Schober's test, which you may be familiar with from the full spine exam. Essentially, what you have to do is you put 2 fingers. You place fingers on 2 adjacent lumbar vertebrae, and you ask the patient to bend forward and touch their toes. And you're observing the change in distance. Okay? You're observing the change in distance. And then after that, you look at the cervical spine. So you want to ask them to tilt their head so their ear touches their shoulder. Okay, just like that. Nothing too difficult. And it might be useful to demonstrate to the patient by doing it on yourself. Okay, and that should be 45 degrees of movement is normal on both sides. Okay. The next one is arms. So the first part of arms, what you need to do is ask them to put their hands behind the head singular, with their elbows pointed out to the side like this. Okay. So this assesses a good couple of things. So it assesses for elbow flexion, and also the kind of how good the glenohumeral joint is. Additionally, it's an important functional test because you need to do this movement to do things like combing your hair or washing your hair. So it's very important.
I didn't know you were on Geeky Medics.
Yeah, that's me. That's actually me.
Yeah.
And then so that's the kind of shoulders part of GALS. So moving on, we're going to be looking at the hands. So it's a subset of arms. So you're going to ask them to hold up their hands with their palms facing downwards. Okay. And you want to look at their hands, looking for much of the same thing that Prakhar was talking about earlier. So any clubbing, any obvious joint deformities, anything that's already on the hand. I'm sure you're familiar. Inspecting and then you ask them to turn over with the palms face up. And then again, you're looking for much of the same things as earlier. So any kind of Osler's nodes or more MSK things. So more kind of eminence wasting, that kind of thing is quite important. And then after you kind of do your looking part of the hands, you want to have a feel. Okay, so just as in the hand exam, you want to do the lateral squeeze test over the MCPs. So as you can see, the MCPs are kind of the joints furthest back on the hand, and you do a lateral squeeze. Okay. Yeah, it's pretty straightforward, and you want to do that quite hard. And essentially, what that is for is to elicit pain. So you want to be looking at the patient while you're doing that, because a positive lateral squeeze test indicates some kind of inflammatory arthritis disease. Then you're going on to the move section. So you want to ask them to make a fist covering their nails, like that. Ask them to squeeze your finger as hard as you can. Then ask them to bring each finger in turn to their thumb. So that's opposition. Okay. Excellent. Now we're going on to legs. So it's a very short exam. There's not really much more to it. The legs. So for the legs, I want to ask the patient to lie down flat, and then you place your hand on the patient's knee, looking for crepitus, and you passively fully flex and extend their knee joint. And you want to do that for both knees. And then you want to bend the knee and hip to 90 degrees of flexion, like shown in the photo, and assess for internal and external rotation. Can't really show you on camera very well, but I would recommend watching the Geeky Medics video. The thing about GALS that's another thing about GALS that's quite different, is that you don't do active movements. So for the legs part of GALS, it's just passive. You're doing the entire thing. And then you want to do the patella tap test. So as you can see, it's the test for any kind of like effusions in the knee. So you swipe down and then you tap. Okay, and then you inspect the feet from the end of the bed. Again, same things as the hand, looking for any obvious joint swellings or deformities. And you do the MTP squeeze, which is the equivalent of the MCP squeeze in the hands, as you can see in the photo, assessing the tenderness equally because of arthritic disease. And you want to end the examination by thanking the patient, asking them to redress, and washing your hands. So that's the GALS examination. It's very short. I don't believe the handbook states that you need to do any further investigations. I believe it says something to the effect of you need to like explore any pathologies that are elicited in examination, because the GALS examination itself is a shortened form of the MSK exams. So I would look in the handbook and on Geeky Medics as to what your spiel is after the exam, after the GALS exam. A thing about the GALS exam is that it's because it's so short, it will probably be combined with another one. So GALS will probably, it might be GALS and left shoulder, or GALS and knee.
Just
so
one knee.
Yeah, something like that. So be prepared for them to kind of combine stations, and that should be reflected in your revision and practice. That's pretty much everything from me. Anything you want to say, Frank?
Oh no.
So yeah, just to conclude, just to kind of summarize the GALS, you want to do your 3 questions, as we talked about earlier. Look at their gait, look at them from the front, sides, and back. Lumbar flexion with the 2 fingers on the back. Ask them to do the movements of the cervical spine, hands behind the head, hands face down, turn over, MCP squeeze, make a fist, squeeze the finger as hard as you can, thumb opposition. Then you do the knee flexion, extension, internal and external rotation, the patella tap, and then you squeeze the MTPs. That's pretty much everything in the GALS. It's quite short.
Here's the feedback. If any of you guys are watching in the future, and if this form is still available, see if can we copy this into the chat. I wonder if the recording shows up the chat.
I think it does.
If it does, have a go at that form.
Yes, sir.
See if you guys want to critique us at all.
Please do.
It's all anonymous, so tell us if you like us. Tell us if you don't.
We want to hear it.
We want to hear it. All ears. See if we can get better at this. But, any advice, final words, Ravi Patel?
Yeah, so practice is key with OSCEs. If I could go back and tell my 2B self anything, it would just be start practicing early. It doesn't have to be a lot, just start practicing early with your friends. Get on the wards and practice on patients if you can. It will really help to improve your confidence. That's the main thing. Enjoy the rest of your year.
Yeah. Honestly, it is a dance. We keep repeating the same word. It is a dance at the end of the day. The examiner's looking at your confidence, in how you talk to the patient and how you interact with them, and then in your confidence in the movements as well, basically. They're looking to see, so they're marking you to see if you know the movements. They're not marking you on if you can actually pick up things. There are very few marks for that. The bulk of it, and you will pass if you just know the moves.
Absolutely.
Obviously, you can learn as much as you want in medicine. You can go crazy, but that is the minimum, and obviously you need to build upon that. So, yeah. Unless there's anything else that we need to add. we'll finish the recording. Ta-ta and bye-bye from Prakhar Gupta and
Ravi Patel.
see you later.
See ya.
Oh no!